Welcome back, everyone. We hope you enjoyed your time connecting during our networking reception and learned from our event sponsors. Without their support, events like these are difficult to produce, so I would like to thank you all publicly again. Next up is Ruben Arabalo. Ruben has 16 years of dental laboratory experience with 12 years of digital design and edentulous full arch case planing skills. A graduate from the University of Laverne, Ruben is frequently sought out for technical advice and recognized as an expert in implants and attachments. Ruben joined Preet Corporation in 2008, was named Senior Technician in 2010, promoted to General Manager in 2014, and most recently became Vice President in December of 2018. Ruben, it's a pleasure to have you join us today. Please take us away.
Right, thank you, Shelly, for that introduction, and I'll get the screen share going right now. Right. So, right, almost there. Right. So thank you, everybody, for having us. I want to give a special thanks before we start to the NDA for allowing myself to be here, as well as Preet Corporation to represent this event. And I just want to start off this presentation by showing everybody how excited I am to be here. This is awesome. It's my first industry trade event since I want to say the end of February. Prior to this year and all the situations surrounding COVID-19, I had been on the road probably 20 to 25 weekends a year the last few years at various events, and it's always amazing to go to a different event, see the different people, see the excitement surrounding this industry, and it's just amazing. So I'm excited to be back at it and doing what I love and doing it with the people that I really enjoy spending time with. Want to take a moment to share why I'm here. This is my family. This is what motivates me to be here. It motivates me to be better at what I do every day and help the various people in this industry. My wife, Marissa, my two boys, they're very passionate about baseball. It's something we share. And something I really enjoy doing in my free time is coaching them and watching them just grow and get better at everything they love. Reason I like to share this slide, though, is because we are all here by choice, and it's a choice to be better at what we do, to learn, to share stories, to communicate with others, and really get an opportunity to grow as individuals in the trade we're in. And to me, that's an amazing thing that we can all come together and do that. A little bit about myself and how I got into dental was right out of high school. Wasn't really sure what I wanted to do with my life. Tried to go to community college. That failed. I think I dropped out within 6 months, and I got a job working at the largest private employer here in Santa Maria, California at the time. That was Denmat. And one day I was told I was going to the lab, had no idea what that was. Spent a few years there before I was contacted by Preet. When I was contacted by Preet, the laboratory I worked in previously did nothing removable. No idea what it was. We did contact lens veneers and snap-on smiles. So I remember being at Preet for about 1 week when I was there, and I remember asking our president, Chris, I said, hey, so kind of what exactly do we do? Yeah, it sounds kind of weird. I took a job not knowing what the company was doing at the time, but it was a risk. And Chris told me, hey, we specialize in removable. And at the time I was thinking, okay, cool. You know, didn't want to tell him I had no idea what that meant. So I walked down the stairs from his office and decided, well, I better learn what removable is because it's what I should be doing in my job going forward. And I started my quest, started digging into any books I could get my hands on and really going at taking an approach to learn everything I possibly can about restorative removable dentistry. Along that journey, early on, the 4 areas that really stuck out to me about what removable dentistry is it's to restore function, it's to restore aesthetics, but I also learned a lot about the psychological concerns patients have around tooth loss. And I actually learned a lot about proprioception and root retained overdentures. That was where I had started. And I could talk all day about root retained, but unfortunately that'll have to wait for another day. Today I want to talk a lot about function and the psychological concerns around tooth loss. So the psychological concerns stuck out to me a ton along the journey. It's amazing how many people get to a point where they have maybe 2 teeth left, 3 teeth. And I mean, Jeremiah did a great job talking about partials and application and use, but it still amazes me when somebody gets to this point. Why not do a full arch root retained overdenture or implant retained denture, just a full denture? There's a lot of examples out there. This gentleman is very proud of this last remaining cuspid here, and he should be, but I just think there's more out there for these patients in the way that we could provide service to them and really restore not only their teeth, but also restore their confidence in the way they go about life. We could change the quality of life for these patients. Early on, learning about dentures in particular, this was something that had come out to me. It's patients view dentures as ugly, difficult to eat, reduced taste, painful sore spots, altered speech and appearance. And to me, in the people I've met over my career that are into removable, this is absolutely false. Some of the finest dentistry and life-changing restorations I've seen are removable, and I think that's awesome. I wish we could change these connotations, and I feel we are right now. It's just, they still exist and they're still out there. Example of that is looking at some surveys. This was taken back in 2015 from 5,000 denture wearers. And at the time, 34% of people with dentures says it limits their ability to live life to the fullest. Of those same group, 56% said it impacts their love life. 24% were afraid to kiss passionately. 23% of men, 19% of women being worried about kissing with dentures. And to me, it's really sad. It is really sad that tooth loss and dentures impact somebody's life this much. I know myself, I've been married 12 years. I couldn't imagine not wanting to kiss my wife. Again, going back, 63% of people with dentures keep them a secret. 38% said dentures affect their career. They're intimidated to network with professionals. They lack confidence in meetings. 23% have avoided going on job interviews. This is huge. This is somebody's well-being when it comes to their career, how they go about their life. Another interesting statistic when we talk about tooth loss is resorption or bone loss. And this is an interesting statistic that 75% of denture wearers would have chosen implant treatment had they known about bone loss. And so I like to show this slide because our main focus in what we do is on the patient. It's how we go about communicating to them what the restorations can do for them, how it'll impact their life, their appearance. I've seen now some offices change the way they promote dentures to actually facelift surgery to restore bone loss and tissue loss, muscle loss. So today in this hour, I'd like to focus on the implant overdenture. And looking at this chart here, we can see, a patient with all their natural teeth has 100% of functional capacity. And a patient with no teeth, no denture will have 0% functional capacity. So within our industry in removable, a full lower denture can restore 10% of functional capacity. Upper denture may restore 30% of functional capacity. But the goal is we want to take those patients today and get them to 60% functional capacity. The area we'd focus on is stud attachments for the most part today. There's some advantages, there's also disadvantages. That's why it's important to know all the various options out there when it comes to stud attachments. The first advantage of stud attachments for, say, a fixed implant case is easy hygiene maintenance. The patient can remove it, clean each stud, clean the denture each and every day. Stud attachments help to stabilize the prosthesis. Stud attachments are primarily used to retain the prosthesis. Nice thing about stud attachments, depending how many you have, it's either going to be a tissue supported or abutment supported prosthesis. Each implant in this situation can be independently serviced. Some of the disadvantages, though, when we talk about implant placement, depending on how they're placed, path of insertion could be an issue for the prosthesis. We could talk about not engaging the undercuts of the ridge for retention and stability. Something when we talk about stud attachments versus, say, a fixed case or a overdenture bar case for removable is we do have reduced abutment splinting. And when we talk about stud attachments versus an overdenture bar, we will have reduced stability. So the first area I like to focus on, I like to focus here, right or wrong, is on mini implants. The reason I like to focus on mini implants is there's just so many out there. And a lot of patients have these, right or wrong. I'm not a surgeon. I don't claim to say it's a right treatment, a proper treatment, a wrong treatment. I just know it's my job to help restore these patients and provide that confidence that they may be lacking. And the most popular type is the O-ring type mini implant. And some of the features of the O-ring, it's about 6 millimeters in diameter in some cases to about 4.5 millimeters tall. It's about restorative space it takes. There's multiple retention levels, 2 retentions. You got the white, the black O-rings. It does not correct too much angulation. It's about 10% per implant. And it is the most resilient attachment system. It acts as a shock absorber. It'll protect weaker implants, especially when bone loss is present. And a couple situations here we could take a look at. When mini implants are placed, it seems that a ton of them are placed. We could see in this maxillary arch from about cuspid to cuspid, maybe first bicuspid to first bicuspid. We have 8 implants here. A few other cases we could take a look at after placement. There are 6 implants on the mandible, 5 implants on the other. The pano we're looking at, again, 8 implants in the maxillary, 6 implants in the mandible. So something like this, we could get a lot of retention. We could really help restore some of that functional capacity and provide a lot of confidence that this denture is going to stay in place. It's going to fit well. Somebody's going to be proud to have this denture. One of the other concerns, though, with mini implants is bone loss. Part of my job at PRE is to evaluate x-rays, identify what implants they are, and what restorative components are available for them. And for whatever reason, again, it could be patient related, it could be treatment related. When mini implants come in and the images are sent to be reviewed, there always seems to be a tremendous amount of bone loss. And the reason this is important when we're done with these type of cases and restorations for these patients is based on a study that was in the International Journal of Prosthodontics in 2017. Talks about this was in about being overdenture supported by 2 implants. However, this can go for 4 implants, 6 implants, but it talks about the stability of both maxillary and mandibular dentures is significantly associated with patient satisfaction in both dentures. Patient satisfaction with mandibular overdenture retention, stability, and comfort is influenced by the stability of the maxillary complete denture. The impact of retention on patient satisfaction is site specific, and there's no effect of clinical quality of maxillary or mandible dentures, and does not influence patient classification or satisfaction. But the overall outlining outcome or conclusion from this study was stability of the denture has a stronger influence on patient satisfaction than retention. And I'd like to share this slide in particular. We're looking at a patient who has a tremendous amount of bone loss. In this photo here reminds me of a situation we had probably about 3 years ago, and it did just happen to come from a denturist office. It was through our live chat function on our website, and it was a situation in which the O-rings were replaced in the housings, and the patient was still complaining about lack of retention. And so we talked back and forth. Everything seemed right, replacements of the O-rings. And it dawned on me at one point, I asked the question, when was the last time the denture base had been relined? And as far as the denturist who was helping this patient at that time, they hadn't performed a reline since they had been seeing the patient. So they went through the reline process and restored the stability of the denture base without even changing the O-rings again. And patient satisfaction was much better. No complaints about fit or retention after that. Another issue that can occur is when we're looking at these mini implant cases is when we start to see the square formation here in the O-ring. That's an indication that there's so much vertical movement between this housing and abutment that the O-ring is starting to sit on the square here. Indication it's time to reline it. And this then we'll go back to explaining to our patients what a reline process is, how to go about it, if that wasn't already covered earlier during the original treatment. One of the things I learned over the last couple of days here, I picked up from Esther yesterday, was the expiration date on a denture. That's fantastic communication to the patient about expectations over the time of their restoration. So it's time for a reline. Patient may not know what it is, and they go Google, what is a reline? This is one of the first things that will pop up if you Google reline or denture-based reline. And to me, this is a disservice to these patients because it's not a proper treatment. We need to go about this with a hard laboratory processed reline when we have that much bone loss surrounding these mini implants. So the laboratory reline process that I prefer and talk about is doing 3 vertical tissue stops in a tripod formation on the denture base using a hard lab putty. Take another example here, looking at a maxillary denture base. And in this type of reline, the housings are removed before the impression is going to be taken. Different attachments have different reline procedures. Even some attachments may have multiple reline procedures. It comes down to what, as a denturist, we're most comfortable with. I prefer to keep the housings in the denture base. Some may prefer not to. When we go back intraorally and we're looking at the mini implants, we need to make sure we're blocking out the area in between the mini implants and any undercuts. Now we could do that independently, blocking out each implant, or we could do it where we could block out multiple implants at a time. Idea is we don't want impression material down here tearing or making it hard to pour this impression. In this case, if we've removed the housings, we're going to take an impression directly over the mini implants, and we can see the negative index of the square as well as the ball. And we're going to be able to index the analogs directly into that reline impression to pour up an accurate model to perform the reline. This is the model after it's been poured, and we can go about our standard reline procedures as normal. If we're working on these mini implants, and again, referring back to Esther, the patient's denture has expired and we need a new one, we can take a new impression and we can use our mini implant impression copings. These will fit on, they're similar to a closed tray impression for an implant, large undercut, so they're picked up. We're going to get an accurate representation of exactly where these mini implants are, or when we go to pour our model and make a new denture base or new denture. We could talk various styles of housings for O-rings. There are closed top housings, there are open top housings, different dimensions, different O-rings are used. I see more often that the closed style housings are used, easier for processing, less block out. The open style does have the advantage though, less vertical space required, less interocclusal space, more room for acrylic surrounding the O-ring, surrounding the housing. O-rings, housings can also be picked up directly. Again, the O-ring is placed into the housing, housings placed on the mini implants, and go in, block out surrounding the housing and below it. I like to do a conical shape block out, or ask for a conical shape block out. It makes for an easier path to draw when the patient goes to seat the denture. Going back to the various housings, if we're looking at the open style versus the closed style, we can see block out is required above the abutment. This is to make sure that no acrylic is processed directly to the abutment, creating a fulcrum or fracture point for the restoration. Now, this is a great tool for these mini implant cases. This is the O-ring insertion tool. Those O-rings are super small. It's a pain trying to insert them in the housing. So with this tool, we could place the O-ring on a tabletop, take one end, seat it directly over the O-ring, and we'll place that tip right back on the tool, and turning it slowly, we'll push this O-ring down into this conical channel towards the housing. And at that point, we could punch this O-ring into the housing, saves times, makes our life easier. One thing that we see often with overdentures though is fractures. And these fractures can occur most frequently right at the area of the attachment. With O-ring mini implants, we could see why. We saw earlier when these O-rings start getting the square formation, we know it's because the vertical space between the denture base and bone and supporting tissue has increased with resorption. And as patient functions, this O-ring, being a shock absorber, just keeps going down the abutment, down the square, till the top hits, the top of the implant hits the housing. And it's that fulcrum that snaps the acrylic directly over the housing. And I love this slide. This next slide, I'm going to keep it in every presentation I do one way or another, because it's true with patients and humans in general that fracture happens. Well, at least sometimes. So when we look at that, again, why does it occur directly at the area of the attachment? The attachment as resorption in space is between the denture base, tissue, and bone. All the vertical forces are directed towards that implant or attachment housing. We can give example after example of areas where overdentures will fracture directly at the housings. And one of the fun parts of overdentures fracturing is also, we can see patient repair attempts. Super glue, Gorilla Glue, staples, floss. Patients will come up with all kinds of different ways to repair their dentures to get the most life out of them, rather than going back in the office and having a proper repair done. And another fun slide, we can talk about the different types of headaches created. We got the migraines, stress, hypertension, or sometimes working in dentistry. Myself, I actually like challenges and solving problems. It's one of the joys I get from my career and what I do. And so we could take these cases where we have a straight fracture and find simple solutions to repair them. In this case, we're looking at a midline fracture on a mandibular denture, and we have created a channel directly below the teeth where that fracture originally propagated. And what we're going to use there, rather than metal, is E-fiber. And E-fiber is a flexible glass reinforcement. It's impregnated with BIS-GMA and PMMA, so it's going to bond with repair resins, it'll bond with our processed acrylic. The first step when we're doing a simple repair in this application is we're just going to take some rope racks, brewing wax, and kind of measure the length of the channel we created in the denture base. E-fiber comes packaged in a silicone package. The E-fiber is right here down the center of it. It's clear, it's translucent. And then after we cut the fiber, we're going to place it into the channel and light cure it. At that point, because it's impregnated with the BIS-GMA, it's going to set up in the form we want it to, in the arch of the denture. And we can just add our repair resin directly over top of the E-fiber. And after that, we can see it's completely translucent. Patient won't see it. It's extremely strong because it's bonding with our resin. It's not just a material we're putting in there to strengthen in the resins around it. Our repair resin, our denture-based resins become one with the fiber. And we can polish it, grind on it as normal. Again, completely aesthetic, and it's going to create a stronger denture than the original processed denture with this material. Another fracture problem we see with dentures in general or overdentures is teeth popping off, especially where acrylic could be thin around housings and we don't get a full bonded denture teeth that we normally see. And one easy way of solving this issue or doing a repair is using a material called Permaret, which is a threaded mechanical retention wire. It's easy to use with denture teeth. We start by drilling a pilot hole in the denture tooth. It comes with a holder, a vise holder, that we then thread in the wire. And we could just cut it with a diamond disc, wire cutters, scissors, really anything we want. And now we have this threaded wire sticking out from our denture tooth that's going to increase the mechanical retention between our resins and our denture teeth, preventing pop-off from occurring again. It's also flexible, so if we need to, we can create loops with it for added mechanical retention. It's great for adding a tooth to a partial. Again, great for repairs. It's just a fantastic item to have around when these type of fractures occur, or even before they occur. We could, provide a little bit more confidence to our patients, knowing we're not going to see these types of fractures again. Moving back to overdenture studs, we talk about the locator. Locator is by far the most popular attachment in overdenture use today. Couple of the features. Number one, the popularity was created by the low profile that locator offers. Interocclusal space is extremely important when we're looking at overdentures. The 2.73 millimeter vertical space absolutely was a game changer when locator, and still happens to be a game changer for locator. It does have a 5.5 millimeter diameter, 8 different retention levels. It can accommodate up to 40 degrees divergence between abutments. And the feature that has made locator is that the nylon metal stays in contact with the abutment. The housing pivots around the abutment, creating less wear to the abutment. When using locator attachments, if the patient has 3 or more implants, we want to make sure we're always using the extended range inserts. The nylon mail, again, maintains constant contact with the abutment, and the movement between the nylon and the housing allows our prosthesis to become tissue supported, directing those forces away from the implants. It's fantastic. We can see in the photo, the nylon mail stays in constant contact. Housing rotates around the nylon mail. If we take a deeper dive into that pivoting action that locator provides, it's the denture cap's ability to pivot in any direction over the mail that accommodates a natural movement during occlusion. The attachment will not dislodge. Patients enjoy normal, comfortable chewing function and unparalleled confidence. When we compare locator to attachments that don't have any type of resilient function, we will see that the attachment will dislodge based off opposing forces of occlusion. This is a short video. Let's see if I can play this right. Oh man, this is not going to work for me today. Well, I'm sorry about that. This video is not going to work, and we will continue on through the presentation. That is my fault. I didn't properly select all the features when sharing my screen. Locator, self-aligning. It makes it easy for the patient to position correctly over their overdentures when they're placing them. It overcomes patient problems with inserting and removing overdentures in as little as one visit, and it eliminates additional wear or destruction from the attachments from improper seating. We did previous lecture talk about locators folding in. We will see how we could correct that problem with a different attachment. Talk about cuff height during abutment selection. The cuff height is the area from the implant to the highest point of tissue. How to properly measure for that. We want to make sure that we're only measuring the space from the implant to the tissue on our model. And the 1.5 millimeter female is already built into the attachment measurements. We've seen different situations where cuff height can be measured too tall. Let's say if they're adding that 1.5 when we are being provided a measurement for an abutment, or as well as when cuff height is too short, we'll see that female area, that 1.5 millimeters, it is below tissue level. The housing cannot engage the abutment, lack of retention, no stability, unhappy patient. So different ways to measure for cuff height when we're looking at selecting proper locator abutments for these cases. We can use a perio probe, and then there are various cuff height tools out there. My favorite is the Preet tool, obviously, but I'll show you why when we look at different types of implants, that there's an internal connection in which the probe can slip into. And if we're measuring with the probe intraorally, that when that probe slips in here and we then order, let's say, a 4 millimeter cuff height versus a 2 millimeter from the actual platform, that abutment's going to be too high in the mouth. One of the areas we see this most common is with conical connection implants. Because there is no flat seating surface on the implant for the abutment, the probe is more likely to slide into the implant, creating a tissue depth that is deeper than the actual platform of the implant. With the cuff height and measurement tool, the flat surface extends across the implant side to side, and it won't fall in there, giving inaccurate cuff height measurements. This tool is available in two sizes, one for narrow platform implants and one for regular and wide platform implants. And an additional benefit to this tool is the ability to see, is a specific attachment going to work for where the implants are placed. On the tool, we have the angulation guide, and we can see in one implant is parallel. This implant over here is not parallel to the other implant, but it's within that 20 degrees, 40 degrees total divergence that locator can accommodate. We can look at the process for locators. We can talk about doing a laboratory process, taking the impression. This is going to be using the impression coping that does have a large undercut. It is a little taller, and the one thing I do like about the impression coping, though, it is taller, but that undercut is more aggressive. When the impression material flows around it, it's going to lock it in place. It's not going to move at all. You're going to get a very accurate model after you index the analogs and pour up your model to process on. In the laboratory, when we're looking at processing, we're going to place the housings over the analog with the black insert in the housing to eliminate the vertical movement. It keeps it in its highest vertical position when processing. And afterwards, we're going to use our locator core tool to remove the nylon black processing insert and replace it with any of the 8 retention level inserts for processing. And another option when we're looking at a laboratory process is to create a void when we're doing the laboratory process for the chairside pickup of the housing. That's using this Delrin processing spacer, which our acrylics we're using in the lab will not stick to. And it's going to create a dimension of 6.3 millimeters in diameter by 3.3 millimeters in height in our denture base to be able to pick up that attachment intraorally without taking the time while the patient's in the office to seat the denture, check with indicating paste to make sure that there's enough space for the housing or requiring additional adjustments in the office. And with the use of digital dentistry, we can talk about the locator scan body. This is a great option when we are digitally designing dentures for patients. One of the nice things about the locator scan body is it does have an undercut, and this undercut will transfer to your denture base, and that'll give an additional mechanical retention between your pickup resin that you'll be using intraorally and the processed or milled or printed denture base resin. Workflow requires a digital scan, prosthesis design, either 3D printed or milled denture base, and prosthesis delivery with the chairside pickup of the housing. And to pick up the housing chairside, simple as placing a locator blockout spacer over the abutment, housing over top, making sure we have enough space relieved in the denture base if we didn't use our scan bodies or processing spacers. I will always recommend drilling a small pilot hole through the lingual of the chair, the housing area. That'll allow the excess acrylic to escape. We're going to place our pickup resin on the housings, apply a little bit to the denture base, seat the denture with finger pressure at the area of attachments only, and guide the patient into centric occlusion. It's really important that during this pickup procedure, we are not asking the patient to bite down and exert extra forces that could displace some of the soft tissue in the posterior. This is one of the common issues that occurs when doing a chairside pickup, is because of that extra force and compression of the soft tissue. Now the patient must always apply that amount of pressure if they want that retention during the pickup. So we want a passive seating, finger pressure at the area of the attachments only, and then we can clean up the excess resin, polish the denture base, and it's ready for our patient. Locator has 8 retention levels, a couple different processing inserts depending on if we are doing a stud retained attachment or bar retained attachment. And one of the biggest developments with locator in the past couple of years was the introduction of the 8-pound retention insert, the new purple. New being it's been about 4 years since it's been available. This is just another way to get extra life from these cases or from the abutments that are existing when they start experience or may start experience some wear to them. Based off of time though, I'm going to kind of skip ahead through some of the angled items and talking about lack of retention when it comes to locator. This is a test that we can do intraorally with the patient in the office if we have an extra housing with black insert. Patient comes in, says, I'm not having the retention I once had, or after a chairside pickup, there's a lack of retention, or a week later after delivery, no retention, is we can take this extra housing and just try it on each locator abutment. And if this housing in contact with the locator abutment has retention, we know that the problem is the positioning of the housing in the denture base. If there's no retention, we know it's a problem with the abutment, either needs to be changed out for a higher cuff height, or the abutment may have some wear to it. In the next area I'd like to go is talking about locator RTX. This is the next generation of locator, and this is an attachment that takes 20 years of locator clinical use and addresses the 5 major areas where locator could have been improved. It does maintain the dual retention. One of the advantages is it's an industry standard 050 hex to drive the locator down, and it is a different coating that is more resistant to wear. It's the titanium carbonate coating. It's much stronger than the original gold titanium nitride coating. It's easier for the patient to insert the prosthesis having a conical shape versus a flat shape, eliminating the issue of inserts folding in as the patient's biting it into place, or potentially biting prosthesis into place. The housing and insert can now accommodate up to 60 degrees total divergence between the abutment and path of insertion. The other advantage is the housing is now anodized pink, making it more aesthetic, easier to hide in our restorations. Not seeing it show through. We could see the function between the nylon insert and housing, allowing 60 degrees total divergence. All-in-one packaging, no more having to order processing packages and abutments separately. One of the areas that was addressed recently with Locator RTX is originally when it came out on our 2 implant cases, because there was that 30 degrees divergence, but it required a lot of space in the housing between the insert. And so some patients, like when we were talking about mini implants, could feel that it was almost felt loose because it was moving too much between the housing and nylon. Not so much the way the denture was fitting, but the movement between the housing. The introduction of the limited range inserts, we can see fills that area. And we also have a stop here between the housing and insert. And these inserts should be used on those 2 implant cases. Again, always coming up with solutions for patients with different situations. Zoomed in view, we could see the amount of movement between the housing and insert, accommodating up to that 30 degrees, depending on implant placement, versus the limited range where this housing will stop when it comes in contact with the insert here on the tissue side, as well as less ability to move between the housing and insert on the occlusion side. When we compare dimensions between RTX and locator, we can see that the locator RTX has about 9/100ths of a millimeter diameter increase, and it has about 6/10ths of a millimeter vertical space increase. But for the advantages it presents versus locator, I think it's a great solution. We can also see in this image where the original locator had a nylon insert that was shorter than our housing. That's where we would see score marks up and down abutments. We'll see that in the next slide. With the locator RTX, we no longer have that problem because the insert is longer than the housing. So the insert will always come in contact with the abutment prior to our housing. If we are looking at these abutments, we can see these score marks up and down. And that is because of that little extra length that the housing had versus the insert. It's corrected with the RTX. It'll solve that problem for these patients. We were to look at a case where we're retrofitting abutments from locator to RTX. We can select our new cuff height if they're too tall, too short. This is placing the rubber dam over the abutments and doing a chairside pickup with the new pink anodized housings. Like the original locator, we have the impression copings available, different model analogs available. It's all in one packaging, abutments, housing, different retention inserts, and the easy to use tool. This is a new tool. If you decide to try out a locator case, you will need this tool. It will remove the inserts from the housing as well as place the new insert into the housing. And a quick recap on locator RTX, we can talk about the 60 degrees divergence. We could look at standard locator allowing 10 degrees per implant, using extended range 20 degrees per implant, to RTX that can accommodate up to 30 degrees per implant. The abutment shape being conical allows for an easier path of insertion. The new titanium carbon nitride coating is more aesthetic and harder than the gold titanium nitride coating. And the pink housing is a big difference when we're don't have the space that we normally would in the anterior. And so when we talk about patience and confidence, I like to talk about an audible sound when the patients are inserting their dentures. The ear is a sensory organ, and the more senses that we can include in treatments when patients insert their dentures, better. We talk about feel. They can feel their denture when they insert it, but if we can add an audible click, it'll make a huge difference to patient confidence. And that's where clicks comes in. This is a ball attachment that we can use as an overdenture stud that allows for an audible click when these patients insert their prosthesis. It's a small 2.5 millimeter diameter ball. We do have 3 different retention levels depending on the patient, and it is smaller than a locator housing in diameter at 4 millimeters, and the trade-off is the vertical height of 4 millimeters versus 3 millimeters when we look at or in comparison to locator or RTX. And the unique female is where all of the audible click comes in. The female is sectioned into 4 segments. That allows for the female to flex outward over the height of contour when the patient's seating the prosthesis, and then snap in the undercut, providing that audible click. We can talk about angle correction with clicks. Clicks can correct up to 30 degrees per abutment. And we can do that with paralleling the housing to the path of insertion to the prosthesis. An example here with 4 implants placed at various angles in this mandible, we have corrected the path of insertion of each one of these housings, allowing for easier insertion and removal for this patient. If we were looking at a case where we had limited space on our buccal flange and we were worried about the problem of the denture or the housing showing through the denture acrylic, with clicks, with the ability to pivot that housing back, we could pick up an additional millimeter or 2 space just from moving that housing around the ball. If we were going to do a pickup of the housings intraorally, we can use this fancy tongue depressor tool here to parallel the occlusals of this housing to one path of insertion. Like some of the other attachments we looked at during an intraoral pickup, after seating the housing, we're going to do a block out, and we're going to do that in a conical shape, again, allowing for an easy path of insertion and removal. We're going to create the space in the denture base. And again, we are cutting that hole through the lingual to allow any excess acrylic to express through the lingual, rather than creating a issue where we are seating the, creating a vacuum effect around the intaglio of the denture base. The last attachment I'd like to talk about is hater bars. I talk about them because this is the most common type of overdenture bar attachment in circulation or use. It's a great attachment, quickly going through the advantages and disadvantages. We could look at increased prosthesis stability. It retains the prosthesis, abutment splinting because the bar connects the implants. We can design these cases with either tissue or abutment support, and that'll determine either a resilient or rigid application. This type of bar can accommodate for divergent abutments. It does require increased hygiene, maintenance, and patient dexterity. Long spans can create torque on the abutments. Path of insertion can be an issue sometimes. And it cannot, prosthesis cannot engage undercuts like overdenture studs. And we do need a straight section for rotation. And the biggest thing is space and on the mandible tongue space. With hater bars, there's 4 different retention levels available now. With the nylon clips, we can look at standard retention, reduced retention, increased retention with the red, and the blue is the newest clip, and that's for worn hater bars. Another way to extend life from these restorations for our patients. We can look at the Ackerman clip being a metal clip. Sometimes patients are prone to keep repeatedly folding yellow clips over, and the Ackerman clip can solve that problem. Ackerman clip also solves the problem or adds vertical resiliency in every single application. So when we process, we have a spacer between the clip and bar, and that allows all occlusal forces to be directed to the surrounding soft tissue and bone. Hater bar or hater clips do not have that vertical movement. All movement is rotational. When we're directing forces, we do have to have either one straight section of hater bar for the clips to rotate. The second we introduce multiple sections on different planes, our rotation is lost and it is a fixed restoration, or acts as a fixed abutment supported restoration instead of a resilient tissue supported restoration. We talk about Ackerman clips. We do see the spacer being placed over the bar, then the clip seated. And we block out any area except the exposed clip before processing. And we have an easy, clear path of insertion over the bar. New dentures for hater bars. The easiest way to take an impression, again, blocking out any space between the bar and tissue. We're going to impress directly over the bar. We do not want to use any clips or impression copings. Reason why we don't want to use any clips or impression copings is there is this space here for rotation, and during our impression, we may have that clip or impression coping rotate, and that can create an inaccurate model. After the impression's taken, we can take either the aluminum or Delrin analog, take a diamond disc and cut the segment we need and index that into our impression for an accurate model or cast. Biggest thing with hater clips when we go to process is using the processing spacer. This right here is going to save so much time. What this spacer does is when we place it over the bar, it acts as an automatic block out. So that prevents any acrylic to be processed up against the flange of the clip. We need that space as the patient inserts the prosthesis for the clip to expand outward over the height of contour of the bar and then snap in the undercut of the bar. Real quick processing, and then I need to finish up, is we need to cut the height of the bar or cut the spacers to the height of the hater bar. We're going to place them, or we're going to block out directly around the spacers. We only want the spacer to be exposed. We'll place the housing over top of the processing spacer. There are 2 different types of housings for different applications. We have the traditional housing, which is 0.2 of a millimeter thin. That saves interocclusal vertical space, versus the alignment housing, which will save buccolingual space and have additional mechanical retention surrounding the housing. We can see the dimension difference between the traditional housing and the alignment housing. in which buccal lingual space required for traditional is 5 millimeters. Our vertical space is 1.2 millimeters. With the alignment housing, buccal lingual space becomes 4.2 millimeters, and the increased vertical of 0.3 of a millimeter at 1.5. Lastly is, again, extending the life of these restorations for our patients, and that's the ability of the new vertical, blue hater clip, which the internal dimension is 1.5 millimeters. It's undersized. Traditional hater bar, or all hater bars, should start off at 1.8. After use, the hypochondria can wear down. That's when the blue is indicated. Right. With that, I'd like to thank everybody for taking the time this afternoon to spend with us as we talk about different overdenture solutions we have for patients. The way I like to sum up this is my unique ability. It's where my passion for removable dentistry meets my talent of knowing what's available, understanding that all patients are different, and that acts as my core focus to focus on an individual patient and provide the best solution possible for that patient. Thank you. And because it doesn't set up, we can easily wipe it away either with water or an instrument. It's like Play-Doh for use in the mouth.
Oh, well, that's convenient.
Absolutely.
Can you go over the difference between the RTX 30-degree inserts versus the 15-degree inserts again? Because there's a lot more to unpack there.
Right. Yeah, I wish I can show you. So because of the 30 degrees, the housings move quite a bit around the inserts. In patients with, say, just 2 implants that are placed parallel in the mandible, when RTX was first introduced, those patients had said, oh, my denture feels looser, there's no retention. And it wasn't so much the denture or the retention, it was the movement between the housing and insert. So the limited range were introduced to remove that movement
shift
at that degree. Yeah.
Interesting. So last question for the day. We know you've got to go. What would you say is the #1 advantage of that clicks attachment that you were showing?
By far.
If you had to pick one.
Well, there were 2 actually that I was thinking of, but by far the audible click. Patient security, they can hear that click. I don't have a model here. I thought I did, but when a patient inserts their denture, it really snaps and provides that audible click. Patient's confidence is huge with it.
Oh yeah. I've had that with earrings before. You hear that click and you're like, they're safe, they're in. I know it's not going anywhere, and you can kind of go up out. Well, thank you again so much for your time this afternoon and insight. We're going to take our last break of the day, and we'll resume with our closing presentation on digital dentures at 2:45 p.m. Pacific time, 5:45 p.m. Eastern time. See you all then soon.